So the big question really is, does therapy actually work?
Yeah, it's fundamental, isn't it? For a long time, there was quite a bit of skepticism.
A real sense of, well, is this just talking? Or does it really change things?
Exactly. People wondered if it was more than just, a conversation,
And anyone tuning into this deep dive, you're probably looking for the evidence, right? The solid stuff behind it all.
which is what we're aiming for today. We've looked at the research.
Yep. Our mission is to dig into what the science says is psychotherapy effective. How do we even study that? And what are some of the complexities?
And it helps to start with where that early skepticism came from. The field was pretty young back then.
Totally. And a lot of that skepticism sort of crystallized around one particular study back in 1952, Eysenck.
Ah, yes, Eysenck's paper. It made quite a splash.
It did. He looked at a bunch of older studies and basically concluded that therapy's effects were, and I quote, small or non-existent.
He even suggested that any improvement people saw might just be spontaneous remission, getting better on their own.
Yeah, just natural recovery over time.
And his numbers were striking. He said something like 72% of people in no therapy groups improved anyway.
Right, compared to only 66% for what he called eclectic therapy and just 44% for psychoanalytic therapy.
So you can see why that fueled the debate. Those figures look pretty damning on the surface.
Definitely. But as you'd expect, his methods came under fire pretty quickly.
Oh, absolutely. There were some big questions raised.
Like, were the groups even comparable? Maybe the people in therapy had much more severe problems to begin with.
That's a key criticism. You might be comparing apples and oranges in terms of initial severity.
And also that no therapy group, it wasn't like they were getting no support, was it?
Exactly. That term is a bit misleading. They often got care from doctors, hospital staff, maybe family and friends.
So calling it purely spontaneous remission misses all that other potential help they were getting.
It really does. It highlights how tricky it is to define a true no-treatment condition in the real world.
Okay, so Eysenck stirred the pot, but the criticism pushed things forward towards more rigorous methods.
Which leads us neatly into the meta-analytic revolution.
Meta-analysis. Okay, for listeners, this is basically a statistical tool, right? Combining results from lots of different studies.
Precisely. It lets you get a bigger picture, a more reliable overall finding, hopefully.
And a key idea here is effect size.
Effect size. It's a standardized measure. It tells you the magnitude of the difference between, say, a therapy group and a control group.
How is it calculated, roughly?
You look at the difference between the average scores of the two groups, and then you sort of standardize it using the variability, the standard deviation of the control group. It lets you compare across studies.
Got it. And this is where Smith, Glass, and Miller come in 1980. Huge study.
Landmark work. They applied meta-analysis to psychotherapy, really challenging Eysenck directly.
And they looked at, 475 studies?
Massive number, yeah, covering decades of research. And their finding was, pretty striking.
They found a mean effect size of 0.85.
0.85. Now, that number might sound a bit abstract.
So what does it mean?
It means the average person finishing therapy was better off than 80%. 80% of people who needed therapy but didn't get it.
Wow. Okay, 80%. That's substantial.
It's generally considered a large effect size in social sciences. It suggests a really meaningful practical difference, not just a statistical blip.
And this wasn't just a one-off finding, right?
No, later work like Lipsey and Wilson in '93 looked across many meta-analyses.
And what did they find?
They concluded that the effect sizes for psychological treatments were as good as or even better than effect sizes found for many standard medical and educational interventions.
So therapy works, and it holds its own compared to other established fields.
That was the strong message coming through from this wave of research.
But did they find that one type of therapy was clearly the winner? Like, is CBT better than psychodynamic, or?
That's another really interesting finding. Generally speaking, no. The meta-analyses didn't show one specific type of therapy consistently blowing the others out of the water across the board.
Really? So the dodo bird verdict, everyone has won and all must have prizes.
Sort of. Now, there are some exceptions. There's decent evidence that cognitive behavioral therapies, CBT, might have an edge for specific things, like panic disorder, phobias, maybe OCD.
Okay, so some specificity for certain conditions.
All right. But the overall picture was more about general equivalence. Different approaches seem to lead to similar average outcomes.
Which makes you wonder, If it's not the specific techniques that are so different in effect, what is making therapy work?
Exactly. And that leads to the idea of common factors, something researchers like Lambert and Burgeon really highlighted.
Common factors, meaning things that all therapies share.
Pretty much. Things like experiencing emotional release catharsis,
Yeah.
the quality of the relationship with a therapist, that therapeutic alliance.
Okay, that makes sense.
Also, learning to regulate your behavior, gaining new insights or ways of thinking. Cognitive learning. These might be the core ingredients.
So it's perhaps less about the specific theoretical brand and more about these underlying processes of change.
That's a major perspective, yes. The human connection, the shared principles, might be more fundamental than we initially thought. It has big implications for training, too.
Definitely. Okay, let's shift gears a bit. What about how long someone is in therapy? Does that matter?
Ah, the duration question. Yes, it seems to matter.
Yeah.
The general finding is, unsurprisingly, that longer treatment is often associated with better outcomes.
More is better, generally speaking.
General, yes.
Yeah.
But Howard and colleagues, back in 1996, added some nuance to that.
What did they find?
They found what they called a dose-dependent effect. Improvement happens, but it tends to level off.
Level off. When?
Around 26 sessions, or about 6 months of weekly therapy, they found roughly 75% of patients showed measurable improvement by then.
Okay, 75% at 26 sessions. What about longer? Like a year?
Going up to 52 sessions, a full year, only added a relatively small amount of extra improvement, maybe up to around 85%. So diminishing returns after that 6-month point.
Interesting. So there's a point where you get most of the benefit.
It seems so, on average. And Howard's group also proposed a phase model, thinking about what happens at different points in therapy.
A phase model. Tell me more.
Okay, so early on, maybe the first few sessions, they called it remoralization.
Remoralization, like feeling more hopeful.
Exactly. Tackling that initial sense of hopelessness, despair, getting some hope back. That happens relatively quickly.
Makes sense? Phase 2.
Phase 2, maybe kicking in around session 16 or so, they called remediation. This is more focused on the actual symptoms that brought the person in.
So working directly on the anxiety or the depression or whatever the main issue is.
Right, symptom reduction is the key goal there.
And the third phase.
Rehabilitation. This is the longer-term work. It's about unlearning those ingrained maladaptive patterns, building new, healthier coping skills.
So like solidifying the changes, making them stick for the long haul.
Yes, and the length of this phase can vary a lot depending on the person and the issues.
That model seems really useful. It implies you might look for different kinds of progress at different stages.
Precisely. Your goals and how you measure success might shift. Early on, it's about feeling better. Later, it's about specific symptom change. And eventually, it's about overall functioning and coping.
Okay, another key distinction in the research world is efficacy versus effectiveness studies. What's the difference there?
Ah, yes. This is important. Efficacy studies are like your classic clinical trials. Very controlled.
Like drug trials. Strict criteria for who gets in, standardized treatment manual.
Exactly. The goal is to see if the treatment can work under ideal, pristine conditions. High internal validity.
Okay, and effectiveness studies.
Effectiveness studies are more about the real world. They look at how therapy works in everyday practice with diverse clients, therapists who might adapt the treatment, maybe messier situations.
So more like, does it work out there? In the community clinic or the private practice office?
Yes, they tend to be correlational or quasi-experimental. Better external validity, perhaps.
And is one better than the other?
Well, there's debate. Seligman, for example, argued strongly for effectiveness studies, saying they better reflect actual psychotherapy. He felt efficacy studies stripped away too much of the real-world context.
But others see value in both.
Right. Jacobson and Christensen made a good case that you really need both. Efficacy tells you if a treatment has an effect at all, establishes that baseline potential.
Establishes it can work.
Exactly. Then effectiveness studies tell you about its clinical utility. Does it generalize? Is it feasible? Is it cost-effective in typical settings?
So they answer different but equally important questions.
I think that's the best way to look at it. You need the lab findings and the real-world picture. Bridging that gap is still a challenge.
Okay, so therapy seems generally effective, but is it equally effective for everyone?
Yeah.
What about diverse populations, different racial or ethnic groups?
That's a crucial question. The good news, generally, is that therapy seems to have positive effects across various racial and ethnic groups.
But are the outcomes identical?
Not always. There are some nuances. For instance, a study by Sue and colleagues in Los Angeles County back in '91 found improvement across groups. But they found Hispanic American clients tended to show the best outcomes, followed by Anglo-Americans, then Asian Americans, and then African Americans in that specific study and setting.
Interesting. What about who even uses therapy services? Are there differences there?
Oh, definitely. Utilization rates vary quite a bit.
How so?
Well, for example, research often shows African Americans are underrepresented in overall mental health service use compared to whites, but they might be overrepresented in psychiatric emergency rooms or inpatient settings.
Okay, so different patterns of use.
Right, and Asian Americans tend to be underrepresented in both outpatient and inpatient services. There are also differences in treatment rates for specific issues like depression or substance use across groups.
It sounds like access and maybe the type of care received could be big factors.
Absolutely. Access, cultural factors, stigma, it's complex.
Another issue is people stopping therapy early premature termination.
Yes, that's a significant concern. The research pretty consistently shows that overall, clients from ethnic and cultural minority groups are more likely to drop out of therapy early compared to white clients.
How much more likely?
Some estimates suggest maybe around 50% dropout after just the first session, which is huge.
50%. Wow. But does it vary?
It can. That same Su et al. Study found that in community mental health settings, dropout rates differed. African Americans had higher rates than whites, but Asian Americans had lower rates, and Hispanic Americans had similar rates to whites in that particular context.
So the setting matters too.
It seems to. Now, an obvious question is, does matching the client and therapist by race or ethnicity help?
Yeah, does that improve outcomes or reduce dropout?
The research there is, well, a bit mixed.
Yeah.
It's not as clear-cut as you might think. Sue's study found matching reduced dropout for some groups, but not others, and only seemed to improve outcomes for Hispanic clients. A later meta-analysis found only a very small, non-significant effect of matching on just staying in therapy longer.
So it's not a magic bullet.
Doesn't seem to be, universally.
Yeah.
It seems like whether a client prefers an ethnically similar therapist and whether matching helps can depend on lots of individual things,
Like what?
like how strongly they identify with their culture, their level of acculturation, maybe gender, their past experiences with trust.
So it's very personal.
Right. And interestingly, for many clients, things like the therapist's training, their shared values or worldview might actually be more important than sharing the same racial background,
That makes sense. It's about the connection and perceived competence.
which raises interesting questions about cross-cultural therapy skills, doesn't it?
It really does.
Yeah.
Okay, let's talk about older adults. Is therapy effective for them?
Yes, absolutely. That's another area where the research is quite positive.
What are the common issues older adults face?
Anxiety, depression, and cognitive impairment are among the most common mental health concerns. But it's vital to remember older adults are incredibly diverse.
Not a monolithic group.
Not at all. Their mental health is shaped by a unique mix of life history, health status, social support, economic factors.
But therapy helps.
Yes, studies show they respond well, often comparably to younger adults, although sometimes the pace of change might be a bit slower.
Are there specific therapies that work best?
Well, a meta-analysis by Gatz and colleagues identified some promising approaches. For dementia-related behavior problems, behavioral and environmental interventions seem well established.
Okay. What else?
Memory and cognitive retraining were found probably efficacious for dementia itself. And for depression in older adults, cognitive therapy, behavioral therapy, and brief psychodynamic therapy all showed good evidence.
So various approaches can work.
Yes, but the key is tailoring the intervention. You need to consider their specific needs, maybe involve caregivers, adapt to their environment, adjust for any age-related cognitive changes like processing speed.
Makes sense. It needs to fit the person and their context.
Exactly. It highlights the need for therapists to be skilled in working with the unique aspects of aging.
Okay, shifting to a really difficult topic. Interventions for victims of spousal or partner abuse.
Yes, a critical area. And the statistics are stark: women experience intimate partner violence at much higher rates than men.
What do the numbers look like?
The National Violence Against Women Survey found over 20% of women reported being physically assaulted by a partner, compared to about 7% of men. Significant difference.
Are there factors associated with higher risk for women?
Research suggests things like younger age, being heterosexual, identifying as American Indian or Alaska Native followed by African American, and having a low income are associated with higher rates. And low income was also linked to the violence continuing.
So what are the guidelines for therapists working with survivors?
Petretic, Jackson, and Jackson outlined some key principles back in '96. The absolute priority is the survivor's self-determination and safety.
Safety planning must be central.
Crucial. Interventions should also focus on building self-esteem, empowerment, a sense of control. Using validated assessments and treatments is also stressed.
And considering the context.
Yes, cultural and contextual factors are vital, and therapists need to be aware of their own potential vicarious traumatization from hearing these stories. Self-care is essential.
What about couples therapy in these situations? Is that ever appropriate?
That's a contentious issue. There's a distinction made sometimes between expressive abuse, maybe more mutual emotional outbursts, followed by remorse and instrumental abuse.
Instrumental meaning.
Planned, one-sided, goal-directed violence, often without remorse. Conjoint therapy might possibly be considered in some expressive cases very carefully, but it's generally seen as contraindicated and dangerous in instrumental abuse situations. Victim safety has to come first.
Separate services are usually the recommendation then.
For instrumental abuse, definitely. And we also need to understand why someone might stay in an abusive relationship. It's complex.
What factors keep people trapped?
Things like emotional commitment, economic dependence, hoping the abuser will change, and critically, fear. Fear of retaliation against themselves or their children if they try to leave.
It's incredibly difficult. Prioritizing safety and empowerment seems absolutely key.
It has to be.
Okay, let's touch on a few other sort of practical issues in therapy. Treatment manuals, what are they for?
Manuals. They were developed mainly for research to standardize the therapy so you could test it consistently. They also serve as training guides.
What's typically in them?
Usually the theory behind the therapy, the main goals, specific techniques, step-by-step procedures, maybe even sample dialogue.
Do people like them? Are they
Yes.
controversial?
Both. The benefit is they help disseminate treatments that have research support and give therapists a clear framework.
But the criticisms.
Some worry they oversimplify therapy, make it too rigid, like painting by numbers. The therapist might just follow the manual instead of tailoring things to the individual client.
A potential loss of flexibility.
Exactly. It's an ongoing debate about standardization versus clinical judgment.
What about the placebo effect in therapy research? How does that work? It's not like giving a sugar pill.
Right. In psychotherapy research, placebo usually refers to the non-specific factors, just getting attention, having someone listen, feeling supported, having hope.
The general aspects of being in a therapeutic relationship.
Yes. And interestingly, these placebo conditions often lead to more improvement than no treatment at all.
So those non-specifics have a real effect.
They seem to, which has led some to question how useful placebo controls really are for isolating the truly active ingredients of specific therapies. If the placebo itself is powerful, what are we comparing against?
Another term I've heard is diagnostic overshadowing. What's that?
Originally, it meant clinicians attributing all of a person's psychiatric symptoms solely to their intellectual disability, overlooking other potential diagnoses.
So one diagnosis casts a shadow over everything else.
Precisely. But the concept's been broadened. It can happen with other conditions too, like a physical illness overshadowing a mental health issue or vice versa. There's even vocational overshadowing, where job problems are ignored because of a mental health diagnosis.
Does it depend on the therapist's experience?
Interestingly, no. Research suggests it's not really related to experience level or theoretical orientation. It seems more like a general cognitive bias we can all fall prey to.
Good to be aware of. Then there's alloplastic versus autoplastic interventions.
Simple distinction, really. Alloplastic interventions aim to change the environment to better suit the person.
Okay, changing the external situation.
Right. Autoplastic interventions aim to change the individual, their thoughts, feelings, behaviors, so they can adapt better to their environment.
Changing the internal world. Most therapy involves a bit of both, I imagine.
Often, yes. But the emphasis might differ.
And what about the therapists themselves? Is therapist distress a known issue?
It definitely is. Research, like a survey by Guy and colleagues, found that personal distress among therapists is quite common, and it can impact their work.
What are the big stressors for therapists?
Dealing with suicidal clients is often cited as a major stressor. Also, feeling like therapy isn't progressing, lack of success, and navigating complex ethical issues like confidentiality dilemmas.
It's demanding work.
Extremely. Burnout is a real risk.
Finally, let's touch on psychiatric hospitalization. Are there patterns in who gets admitted?
Yes, some interesting demographic patterns emerge from the data.
Like what?
Well, paradoxically, while women generally report higher rates of mental illness, men tend to be admitted to state and county psychiatric hospitals more often.
Why might that be?
One theory is differences in how distress is expressed. Maybe men are more likely to show acting out, behaviors that are seen as requiring containment. Also, shifts in commitment criteria towards focusing on dangerousness might play a role.
Any other demographic trends?
Admission rates are often highest for people who've never been married. Racially, while whites are the largest group numerically, individuals from other racial ethnic groups are often overrepresented relative to their proportion in the general population.
What about age and diagnosis?
The biggest chunk of admissions is usually the 25-44 age group, where schizophrenia is often the most common diagnosis. For older adults, 65-plus Awitterge, organic disorders become more frequent diagnoses, leading to admission.
And newer data, does it show the same things?
More recent surveys still suggest men are admitted more to inpatient, but women more to outpatient. And white individuals remain the majority in both settings overall.
Okay, so wrapping this all up, quite a journey through the research.
It really is, from Eysenck's initial challenge to decades of studies refining our understanding.
And the big takeaway seems pretty clear. Therapy, generally speaking, works. Meta-analyses show significant effects.
Yes, the evidence is quite robust on that point. The average person benefits substantially compared to being untreated.
We also saw that how long you're in therapy matters, but maybe with diminishing returns after a point. And that phase model, remoralization, remediation, rehabilitation gives a nice framework.
Right, and the importance of understanding efficacy versus effectiveness, the lab versus the real world.
And critically, thinking about who therapy is for considering diverse populations, older adults, survivors of abuse, the need for tailored approaches.
Absolutely. And acknowledging the complexities like treatment manuals, placebos, therapist well-being. It's not a simple picture.
For you, our listener, hopefully this deep dive gives you a solid, evidence-based way to think about psychotherapy. It's not just talk, there's real science behind its effectiveness.
The field has come a long way in demonstrating that.
Which leaves us with a final thought, maybe something for you to ponder.
Given that we know psychotherapy is generally effective, what are the biggest barriers stopping more people from actually getting it and benefiting from it?
Yeah, what stands in the way? Is it cost, access, stigma, systemic issues?
It's likely a mix of all those things and more. Something complex to think about, considering how beneficial these interventions can be.